In this video, I will show you about vitrectomy in advanced proliferative diabetic retinopathy with dense vitreous hemorrhage. This patient came to us with an intraocular pressure of nearly 50 and a dense vitreous hemorrhage where we cannot see the retinal. And initially we kept from anti-glaucoma medications. Now the pressure has come to nearly 15 to 18, and then we have taken up for the vitrectomy surgery. Pre-operative 5 days we have given an anti-VEGF injection. The vitrectomy is being done with 25 gauged valve trocars. So initially I made a AC paracentesis and then I cleared the anterior chamber. You can see the hemorrhage which is coming from the angles. So you can see the clearing of the cornea and the anterior chamber. Now the anterior chamber is much better. It is always better in these cases to first clear the anterior chamber. Now we will see what's happening inside. You can see the dense vitreous hemorrhage. You cannot see retinal areas. I started with the peripheral vitrectomy. We should remember in diabetic vitrectomies it is always advised to go to the peripheral vitrectomy first, because you never know what are the tractional points if you directly go into the vitreous posterior vitreous detachment. Don't induce PVD. Always do a peripheral vitrectomy. Slowly we can see the retina. You can see a dense hemorrhage lying over the macular area. You can see the laser marks which were done elsewhere. So now I am doing a peripheral vitrectomy and slowly getting the view of the retina. On the temporal side, the vitreous is cleared, and on the nasal side, it is still attached to the retina. I think there is a tractional point on the nasal side. So I just want to clear the other areas first, leaving the nasal side. Once I am fine with the other sides, then we will go into the nasal side. I think now we can see the tractional point, and that is the point where the bleeding has started. Be gentle, take your time. I am using a soft tip flute cannula to aspirate the hemorrhage over the macular area. When I am doing this, I'll raise the infusion to 50 to 60. It takes a lot of time. Be patient. Don't be in a hurry. A unwanted retinal hole or a tear is more damaging. So I cleared the macular area, a little bit of tricot, and see what the vitreous status. And now these are the two focal tractional points which has caused the vitreous hemorrhage. Go close to it, assess it deeply, be gentle and relieve the traction. I'm just desegmenting it. Just be careful. Now the traction is relieved. Trim the edges. Use the lowest possible vacuum. Now the vitreous traction is relieved. Cut and aspirate the maximum vitreous we can. Checking out the peripheral retina for any breaks or holes. As I couldn't see anything, I'm going ahead with the ILM peeling. I used Trypan blue. Now ILM peeling is done by pinch and peel technique. This is a Gray Shaver's 25 gauge ILM forceps. Just raise the flap and then you can hold it and pull it. Hold it and gently pull it. It is always better to pull it away from the disc. Again I am aspirating the vitreous hemorrhage, the fluid cannula, the soft tip fluid cannula. I could see the bleeding points. I'm cauterizing it, applying diathermy over the bleeding points. Doing a endo laser. Inferior retina is not lasered, other areas are lasered. Do a complete fluid air exchange. All the hemorrhage needs to be aspirated. Take your time. I always prefer to use passive fluid air exchange. Now the case looks to be fine. Thank you for watching.